Let me share my screen. Good to see my slide. Okay, let's get started. So today we're going to talk about GI, but not really specific to GI. Some of the soft tissue thing, we just have four topics, and some topic I've never seen during my residency, but we still will go through it. Here is the topic. So before I go through all the topic, just show you something really useful when you see this spindle thing. So today in our topic, you will see these three different cell types. The first one is fibroblast, and then we have a nucleus, and then we have this rough endoplasmic reticulum, and then the label in blue. So the cells look like really dark and a little bit hyperchromatic nucleus. And then we have smooth muscle cells, and then we have this myofilament. So the cell cytoplasm is kind of pink. And then you can also compare to the nuclear shape. This one is more uh, pinky sharp end, and then this one we have a blunt end. Just we will describe it like a cigar shape. So this is the small muscle cells. And then you can see the cytoplasm between these fibroblasts. We have this kind of wavy cytoplasm. That is the collagen deposition. So this is a fibroblast. And then between these two, we can see this myofilament. So even in this comparison, we can see they are different in color and also shape. And then the last one is the myofibroblast. This one is we can see some overlapping of the cytoplasm. We have this rough endoplasmic reticulum, and then we also can see this myofilament. And then in the H&E, we can see the nucleus is quite different from these two because we can see more open chromatin, and then we can see the nucleoli, not even just one. Sometimes we can see two and even three. But this nucleoli is not prominent usually. I mean, most of the cell, you can see some nuclei may be a little bit bigger, but most of the cell you can see this nucleoli with this open chromatin. And then the cytoplasm is kind of a amphiphilic, a little bit purplish, but just lighter. So when we recognize these three cell types in today's chapter, will be much easier for you to identify the diagnosis. So and then the first one is sclerosing mesenteritis. So this is a surgical image. So we can see the bowel is here, and then we have some mesenteric kind of like thickening, shortening, and line string together. So this is the surgical finding. And then you should remember this entity is related to older male because we have another entity. Uh, we may see the same molecular microscopic finding, but more commonly in female. So in the microscopic finding, we can see this nodular, they're forming this nodule with fat necrosis inside. And then surrounding the necrosis, we can see this spindle perforation of the fibroblast. This thing is fibroblast because we can see some collagen bundle between the cell, but for this resolution of the image, you just could not tell. And then the fat necrosis is really characteristic, and also we can see some lymphoid aggregation around. Compared to this looks healthy adipocytes, this fat necrosis, why even in low power we can recognize it because usually the healthy adipocyte they will grow back to back. So there is usually not a lot of stroma between the adipocytes. But this fat necrosis, we can see the stroma is thickening, and then their color is kind of pink, pinkish looking, and then usually just histiocyte between the fat cell. And then higher power, we can see this fat necrosis. They have thickening stroma between the adipocyte, and then lymphoid aggregation. Higher power, we can see some foamy histiocyte to try to clean some of the debris, I think, from the adipocyte. The other one is the Weber-Christian disease. So this one, in the microscopic, the finding are identical to the previous one, but the predominant gender is female. And then, but for this one, we can see more different location of the fat necrosis. So in the sub-Q, we will call this panniculitis. And then the patient may also have malaise and fever. They can get involved in other organ as well, but the microscopic findings are the same. So let's see one virtual example. So low power, we can see we have some lobulated fat adipocyte tissue, and then some area looks healthy, but in this area, in low power, we can recognize this lymphoid aggregation, and then we also can see that this hole not back to back compared to the healthy one because they are fat necrosis. I can go a little bit higher power. We can see the fat cell in between. They have this hyalinized stroma and a lot of inflammatory cell here. So this is nodular fat necrosis surrounding by this fibroblast. So I think in the proper clinical setting, we can make that diagnosis sclerosing mesenteritis. So this is one of the example of this entity. I've never seen one. Okay, the other big category, I think this one in the board examination, you may probably see one. This one is inflammatory myofibroblastic tumor. So this is a true neoplasm, uh, usually seen in the younger age group. And then half of this case will have this ALK gene rearrangement, and they can get involved in the GI uh, mesenteric and also often in the lung. The prognosis is generally good, but some of the cases may recur, but less than 5% may metastasis. And then the gross picture, just like what we can see in the cutting surface of a sarcoma, so they call it sarcoma-like. So there's just this whitish fibrotic cutting surface. They usually have this multi-lobulated looking. And for the histology feature, from the name, we already know this inflammatory, so we should see inflammatory cell. We should see a lot, not just a little bit. We should see a lot mixed inflammatory cell, including neutrophil, eosinophil, even plasma cell. So remember, this one is really important because some of the cell type usually in other entity we rarely see, especially remember the neutrophil and the plasma cell. So other than the inflammatory part, we have this myofibroblastic part. So in the stroma, we have this edematous myxoides stroma, and then we have this proliferation of this spindle cell. So this is a myofibroblast. And in this magnification, you just could not appreciate the open chromatin and conspicuous nucleoli, but I have more images to show you. You just remember this is the spindle cell proliferation in this myxoid stroma. Of course, the cell for this entity, they can have different cellularity. They can have this hypocellular area and even some hypercellular area. In the hypercellular area, they usually this spindle cell neoplasm can form this vesicle growth, even storiform and herringbone. And then their cytoplasm is kind of light purplish, this amphiphilic cytoplasm, characteristic for this entity. Then he just showed this bluish myxoid background for this spindle cell proliferation, and then they also can form this vesicle. So the spindle cell just one end connect to the other end, and then forming something like a car in a in a highway. So this is a vesicular growth pattern. Of course, they have this hemorrhage. So sometimes this kind of spindle cell proliferation usually mimic nodular fasciitis because they have some overlap feature. And then this one is really characteristic. We can see sheet of plasma cell. So this kind of really unique for this entity. And then they can have this lysarcoma growth pattern, the herringbone, like the synovial sarcoma and other sarcoma. But for the cytology, we can still tell this is a myofibroblast. And then they, in the hypocellular area, they can forming this hyaline stroma. And also they can have this sclerosis stroma. Why I say this is sclerosis and not fibrosis? Because in between the cell, we can see this thickened collagen bundle, but no nucleus inside. If we see a lot of nucleus, we should call this fibrosis, not sclerosis. And then they can forming this rake storiform growth pattern. So in this higher power, I want to show you the nuclear feature of this myofibroblast differentiation. So first, other than this spindle cell, we can see tons of inflammatory cell. And then this is the really characteristic myofibroblast differentiation. We can see this open chromatin, and then in this cell even we can see maybe 3 or 4 conspicuous nucleoli. They are usually not prominent. Of course, you can see some maybe prominent nucleoli, but most of the nucleoli, you can see it, but not really big. And then they have this amphiphilic cytoplasm, really characteristic, conspicuous nucleoli. And then sometimes, because they can also, these fibroblasts can fuse together, so you may see this prominent nucleoli forming this Sternberg-like cell, but actually they are not. They can also have this smudge cell, have really hyperchromatic nuclear feature. But you can see for the other cell, they still maintain the myofibroblast differentiation. You can just tell them apart. Let's show you some virtual slide example. So low power, we know we have some hypocellular area and hypercellular area. In the hypocellular area, we have this edematous myxoid stroma. We can see spindle cell perforation. They're almost forming this vesicular growth, especially in this hypercellular area, more like some growth pattern of vesicular growth, like here. A little bit mimic fibromatosis, and then we can see a lot of extravasate red blood cell. And then some area we will find, here. We can see a lot of inflammatory cell infiltrate. And then we can have some neutrophil plasma cell, especially if we find these two population, you should think of this entity because this is inflammatory myofibroblastic tumor. So and then take a look at the nuclear feature. You can see open chromatin, conspicuous nucleoli, and then this amphiphilic cytoplasm. So this is maintaining the myofibroblast differentiation. So this is one of the example of IMT. And then remember ALK. This is another example. We also have this hypocellular and hypercellular area. And then hypercellular area, we can see this vesicular growth pattern. Hypocellular area, we can see this myxoid edematous stroma. And then, of course, we want to see some inflammatory cell. We have a lot here. You don't need to look for them for a long time because you can easily tell them. And then the spindle cell, they maintain this myofibroblast differentiation, open chromatin, conspicuous nucleoli. and then this amphiphilic cytoplasm. They do not forming that wavy, a lot of wavy collagen between the cell, not like fibroblasts. Last example, also some hypocellular and hypercellular area. Hypercellular area, they forming this physical growth. And then even here, we can see a lot of inflammatory cells in the background. And nuclear feature, you can see open chromatin, conspicuous nuclear OLI. They all look like the same. Okay, for the ISC pattern, usually they are SMA positive, and that's mean the variable, because that's mean usually they highlight the muscle cell, but this is myofibroblast. This is not muscle cell, so they have variable expression of desmoid. And then ALK is really important for this entity, even we just can see in 50 to 60% of the case. If the ALK negative, you can try the ROS one, because this is another arrangement for this entity. And then for this track rearrangement, right now in the new entity, they may not fall into the IMT category, because we have a new entity called the N-track rearrangement spindle cell neoplasm. So in that entity, they most likely fall into that category and not into the IMT. So I don't think track is helpful here. And of course, for other spindle cell differentiation, differential diagnosis, S100 SOX10 negative, so they are not swan cell, and myogenic because they are not muscle cell, and then also CD117 negative and EMA negative. So for some differential diagnosis, I think the most important one is the nodular fasciitis, because they have a lot of overlapping feature. So for the IMT, they usually happen in the trunk, and then an internal organ like lung. But for nodular fasciitis, they usually happen in the extremity, because one of the hypotheses is that the patient get trauma or something can induce nodular fasciitis. So sometimes we can see it in the breast. And then they usually smaller size, less than 3 centimeter. And then one important diagnostic feature is the cystic changes. That is the cystic degeneration. This is more characteristic to the nodular fasciitis entity. And of course, we have this tissue culture-like fibroblast. But honestly, for this feature, IMT can have this overlapping so-called tissue culture-like fibroblast. And then from the molecular, of course, ALK should be negative in the nodular fasciitis, and then we can send for the USP6 rearrangement for the final diagnosis. And then the most important, most common partner is the MYHI USP6. This is one of the example of nodular fasciitis. So even in low power, you notice this cystic degeneration changes here. So you usually do not see this feature in the IMT. And then take a look at it. They also show this fibroblast perforation, and then sometimes you can see mitosis in this entity. But you can see they should have this myofibroblast differentiation, open chromatin and conspicular nucleoli. So that's the reason I would say that they have overlapping feature with the IMT. And then this area, you can see somewhat called the tissue culture-like fibroblast. But honestly, from my eyes, kind of overlapping with the IMT. But you can see I go through this high power for a little bit. It looks like not really easy to see tons of inflammatory cell. Maybe sometimes you can see some lymphocytes, but definitely you won't see sheets of plasma cell and even neutrophil, because this is not the characteristic feature of nodular fasciitis. Of course, they can have this extravasated red blood cell we can easily find. So this one is nodular fasciitis. They're usually smaller than the IMT. The other differential diagnosis is leiomyosarcoma. From the first slide, I already showed you how the muscle cell differentiation looking. They have this cicatrate blunt end of the nucleus, and then their chromatin is not as open as the myofibroblast. And they usually uh, lack lymphoplasmacytic infiltration. So that's the reason I mentioned the plasma cell and neutrophil in the IMT. That is important feature of that entity. Of course, leiomyosarcoma, they have other variant. They can also show myxoid stroma and even some prominent inflammation. And they usually in a deep soft tissue mass and also in the GIN. And usually you will see this classic leiomyosarcoma morphology, even you have the myxoid leiomyosarcoma. And of course, IFC staining will have this diffuse SMA and also desmin, ALK negative, because no transfusion or translocation is found in leiomyosarcoma. The cells show really highly polymorphism because they are not translocation-driven soft tissue mass. And then the last differential is this pseudo sarcomatous myofibroblastic proliferation. They have a lot of overlapping even in the clinic and the pathology finding with IMT. So still have some controversy, not clear whether uh, they are in the same entity. But the anatomic side involves should be gentle urinary tract, typically in the bladder. They also show ALK rearrangement. FM1 ALK fusion is common, but ROS1 usually negative in these cases. So the last entity I'm going to talk about is desmoid fibromatosis. So this one is combined fibroblast and myofibroblast proliferation, usually in the deep soft tissue, but also you can see in the abdomen, you can see the CT scan show this mass, and then the cutting surface is, we can see some uh, hemorrhage and also this fibrotic looking cutting surface and associated with FAP sometimes. So for the microscopic feature, we can see myofibroblast and fibroblast proliferation. But for the characteristic feature, you can see they forming this long vesicle. It should be really long, just a short one. They should forming a long vesicle and then infiltrated to the normal architecture. And then let me show you some image. Yeah, they will form this long vesicle, and then you can see between the spindle cell, you can see this wavy collagen because they are a mix of fibroblast and myofibroblast. So for the fibroblast, they should deposition of this wavy collagen. They are forming this long vesicle. Then they can also forming this loose storiform growth, use the imagination. And then one characteristic feature is that this is a vessel, and then they also have this clear space around the vessel. You can call also this is edema around the vessel, one of the characteristic feature if you can find it. And then because you can see these fibroblasts, myofibroblasts just like expansion between the vessel, so the vessel they can forming this dilated vessel, they call it gapping vessel, like this kind of rigid looking of the vessel. And then if in the abdominal, of course, they can show infiltration of the mesenteric, and then they also can wrap the muscle cell. And then for the IHC, still SMA positive, because SMA we know this is not specific at all. But for other staining, desmin can be really rare focal positive, and then CD34S100 stat for the SFT, all of these are negative. And nuclear and cytoplastic staining of beta catenin can be seen in 75% of the cases. If the sporadic one, it should be related to the mutation of the beta-catenin, that is the CTNNB1 gene. If in the FAP or Gardner syndrome patient, they may find this inactivated germline mutation in the APC gene in the 5q. So this is the cytoplasmic and nuclear staining of beta-catenin in this spindle cell. Let's see some example. This is a small colon, and we can see this is a normal muscle layer, musculary mucosa, propria, and then we can see this pinkish spindle cell perforation kind of infiltrated even into the fat and then into the muscle. And then we can see this collagen, kind of wavy collagen between this spindle cell perforation. This case, they are not forming really obvious vesicle growth, but this growth pattern with this spindle cell perforation is good for the fibromatosis. This is another better example. We can see this is the fascia really deep and then muscle cell. And then we can see some spindle cell perforation forming this really long vesicle. Even in this scanning magnification, we can see this vesicle is forming really long. And then high power, we can see they show some cells show this open chromatin with this conspicuous nucleoli. So before in the category of a myofibroblast. And then, but this in between these cells, they also have this wavy collagen deposition. So some of these darker cells should be fibroblasts. This is a characteristic feature of this one. And one other feature is you can see they're wrapping this muscle cell. And then they can, because they're wrapping this muscle cell, so it can cause atrophy of this muscle cell. So you can see this multinuclear cell. They are not multinucleus like of the histiocyte. They are atrophy muscle cell. So the nucleus string together because they are wrapping by this collagen bundle. They are not healthy. So they're forming this structure. And then for this one, you can also see spindle cell perforation forming this wavy collagen and then long vesicle. And then for this one, I would like to show you one feature of that. Yes, around the vessel, we can see these edemas. So they have this lighter color edemas surround the vessel. This is one of the characteristic finding of this fibromatosis. And I think that is all I have. And one had any question or any comment?